All right, let's talk about something the NCLEX just loves to throw at you: peritonitis. And look, this isn't about just memorizing a bunch of facts. This is about being a clinical detective, spotting a killer that's hiding in plain sight, and knowing exactly what to do to save a life. You ready? Let's get into it.
Okay, so imagine this. You walk into your patient's room, right? And you glance over at their peritoneal dialysis drain bag. And something's not right. It's not clear like it should be. It's cloudy, murky. What is the number one thing that should be screaming in your head right now? What's that big red alarm bell that just started ringing?
Yeah, that right there, that's the problem. And I'm telling you, this is not some small thing you just chart and move on. For the NCLEX, and way more importantly for your actual patient, that cloudy effluent, that's the medical term for it, is a giant, flashing neon red flag. It's the classic sign of a really bad infection that's brewing deep inside the abdomen. If you were thinking peritonitis, you are absolutely spot on. This is one of those conditions where every second counts, and what you know really matters. So let's break it all down. Everything you need to know to crush those exam questions and, be that nurse who saves the day. All right, let's get into what's happening inside the abdomen. First things first, what even is peritonitis? So, in simple terms, peritonitis is just inflammation of the peritoneum. And the peritoneum, well, it's this super thin, sterile lining that covers the inside of your abdominal wall and wraps around all your abdominal organs. The best way to think about it is like a big sheet of sterile plastic wrap. Its job is to keep everything inside nice and protected in this clean little bubble. But when bacteria manage to get through that barrier, oh man, the whole system is in big trouble. So, the big question is, how do these germs get in there in the first place? Well, for the NCLEX, you want to focus on three main ways. First, you've got spontaneous peritonitis. This usually happens when a patient with, say, liver or kidney failure has infected fluid already in their abdomen. Second, and this is a really common one, is secondary peritonitis. Think of it as a hole somewhere, a ruptured appendix, a perforated ulcer. Something bursts and leaks bacteria everywhere. And third, just like our scenario at the beginning, contamination from peritoneal dialysis, maybe from not using sterile technique.
Okay, here's a huge assessment clue you have to lock in. The pain, it changes. At first, it's kind of vague, just a dull ache all over the belly. But as that infection gets angrier and settles in one spot, the pain becomes sharp, super intense, and you can point right to it. That change, that's a classic telltale sign.
Okay, so why is this such a big deal? Why is peritonitis an absolute killer? In 2 words, sepsis. Emergency. Peritonitis is basically a super highway to sepsis. Here's what happens. That inflammation makes the peritoneum all leaky, kind of like a sieve. So massive amounts of fluid, proteins, electrolytes, everything just starts pouring out of the blood vessels and into the abdominal space. We call that third spacing. Your patient is literally drying out from the inside, dumping all their fluid into their own belly. And that's exactly why their heart rate goes through the roof and their blood pressure just tanks. And all that extra fluid and inflammation, it's just too much for the gut. The bowels just give up. They get overwhelmed and they stop working. It's called a paralytic ileus. The whole GI system literally just shuts down. That's when you see the belly get all big and distended, the patient feels sick, they're vomiting, and of course, that just makes the dehydration even worse. And here it is, the bottom line. Those bacteria don't stay in the belly. They invade the bloodstream, and that's septicemia. This kicks off a massive, body-wide firestorm of inflammation. That's sepsis. And from there, it's a terrifyingly fast spiral to multi-organ damage and ultimately death. This whole chain reaction is why what you do and how fast you do it is so unbelievably important. All right, we get it. It's bad. We know why it's a killer. Now for the part the NCLEX is going to test you on over and over again. What are your first 5 actions? What are the absolute priorities? Think sepsis bundle. You've got 1 hour. Let's run through the steps. And yes, the order matters. Step 1, get those blood cultures. You got to find out what bug you're fighting. But, and this is a huge NCLEX trap, you have to draw them before you hang the antibiotics. Step 2, start broad-spectrum IV antibiotics right away. We can't wait for the culture results. Step 3, push a big ol' fluid bolus to try and counteract all that third spacing and get their BP up. And step 4, measure their lactate levels. A high lactate is basically screaming shock. Okay, so after the big stuff in the sepsis bundle, what else? Well, a few more priorities. First, the patient has to be NPO, nothing by mouth. Their gut isn't working, remember? So we're probably going to need an NG tube to decompress the stomach. Second, that pain is no joke. We need to manage it, usually with IV opioids. And third, get them into a semi-Fowler's position. Propping them up a bit takes some pressure off their diaphragm, and trust me, it makes breathing a whole lot easier for them. Okay, pop quiz time. Mini NCLEX scenario coming at you. A nurse is assessing a patient on peritoneal dialysis. Which one of these findings means you need to call the provider, like, right now? Is it number 1, they're having trouble draining the fluid? Number 2, there's some redness at the access site? Number 3, some fluid is leaking from the catheter site? Or number 4, the effluent is cloudy? Go ahead, pause for a sec, and think about it. What's the biggest, baddest red flag here? And the answer is number 4, cloudy effluent, for sure. Look, the other things aren't great, right? Difficulty draining, some redness, those are problems you definitely need to address. But cloudy effluent, that is the hallmark sign of peritonitis. It's shouting that there's an active, dangerous infection happening now, and it's a medical emergency. That is a perfect example of an NCLEX priority question. They want to see if you can spot the most life-threatening problem. All right, let's do a super quick, rapid recap to burn this into your brain. If you remember nothing else, remember these 3 things for your exam.
Number 1, the key sign. For a patient on PD, it's that cloudy dialysate. You see cloudy, you think peritonitis. Period.
Number 2, the biggest risk. It's always sepsis. This isn't just a simple infection we're talking about. It's a ticking time bomb that can take your patient down fast. And number 3, your top priority. What's the first thing you do? You get that sepsis bundle started. Cultures, antibiotics, fluids, lactate. That's your game plan. Know it, own it. Okay, I'll leave you with one last question to chew on. You've spotted the signs, you've started the sepsis clock. While you're waiting for all the orders to come through, what's a simple, supportive thing you can do for your patient without an order that will immediately help them feel a little better? Think about it. It's all about positioning, right? Getting them into that semi-Fowler's position. That's you using your nursing brain. That's what it's all about. You can totally do this.